subject today is hypercoagulation, mast cell activation, and infections. And Dr. Schwarzbach will be telling us more about this in a moment. Dr. Schwarzbach is a medical doctor and specialist for laboratory medicine. He's the founder of AONM Labs in Germany, a laboratory for tick-borne diseases, and he's been at the forefront of tick-borne research for more than 20 years and is an expert in diagnosing and treating infectious disease. He's an advisory board member of the Academy of Nutritional Medicine in London, and board member of the German Borreliosis Society, and a member of the International Lyme and Associated Diseases Society, ILADS. He's also served as an expert on advisory committees on Lyme disease in Australia, Canada, Ireland, France, England, Sweden, and Germany. So we'll have time for questions afterwards. If you hover with your cursor over the bottom of the screen, you should see a chat bubble, and if you click on that, you can write questions which we'll be able to see and ask at the end. So without further ado, I think, Armin, over to you. Thank you.
Yes, thank you. Hello to everybody around the world, and especially in Europe. Thank you for AONM to organize this webinar again. Thank you, Gillian, for your nice introduction to me. AONM Labs had on 24th of January 5th year anniversary, and we are very happy to proceed with our work, and we want to do a lot of good services for therapists and patients all over the world. Today, the topic is a specific topic, and it's named the association between hypercoagulation, MCAS, which is the abbreviation for mast cell activation syndrome, and infections. And little is known about that. And I myself, I'm always learning when I talk about that. So excuse me if some of the expressions which are as an example, the thrombocytes or so, it's difficult also to do the correct pronunciation. So excuse that if something will go wrong. The question is always, do we have some evidence? Everybody wants evidence-based medicine of pathogen involvement in these two different chapters. In the first part, I will talk about hypercoagulation, the correlation with bacterial and viral pathogens. And in the second part, we will discuss and talk about histamine upregulation, MCAS or MCAD, correlation with stealth infections, also bacterial and virus infections priority. The blood coagulation system is surely activated during infections. It's in a paper written from 2018 clearly that the current view that the activation of the coagulation is a benefit for infections with bacteria and viruses. We come later, why is it beneficial for infections? And the activation of the coagulation system limits the pathogen dissemination and supports the pathogen killing. So coagulation is on one side a good thing, but on the other side a bad thing. And I want to talk about both aspects. In the next slide, you see a vessel. You see that the infection is the first step for an inflammation, and then the inflammation will come to thrombotic response. And in the end of this process, you find a fibrin deposition. This is not so easy to understand, so I think it's better to go to the next slide and come back to that slide again. The question is how infection can trigger this hypercoagulation. There are three different very important steps. In the first step, the infection triggers inflammation, which triggers a thrombotic response. The cytokines, you know, every infection means a cytokine release, so we also can detect this in laboratory. Interleukin-1, 6, and TNF-alpha play important roles in this process of hypercoagulation. The cytokines from the white blood cells, leukocytes in this case, are released into the blood to protect the body from a foreign attack. By that process, they induce the expression of tissue factor TF on the endothelial cells surfaces. And this drives the coagulation cascade. So we can go back to the slide 4. You see that process, bacteria or viral or fungal or whatever parasites are coming into your blood system systemically, and by the process there's a release of TNF-alpha and interleukin-1 and 6, and by the monocytes, and by this process you have an inflammatory response to the infection. Going back to the next slide. Also antibodies formed in an immune response to the pathogens, whatever pathogen it is. This is a principle which is not pathogen specific. And this contributes to the local generation of thrombin. The thrombin plays a very, very important role in this hypercoagulation process. The thrombin triggers the fibrin formation. We go now back to slide 4. There you can see exactly what it means. The thrombotic response you see in the middle field is a general response to infections, and by this cascade of coagulation, there's an overproduction of factor 8 and also factor 5. And by this coagulation process, the body is producing more thrombin. But this is not all in this process. You know, if that would be a reality, we would not survive that process of hypercoagulation. So we need activated protein C, and activated protein C is the contradiction to the hypercoagulation process. But in this also I want to mention we have patients with activated protein C resistances, and that means if you have this genetic mutation, which plays also a role in this, you have a higher risk for thrombosis. And by this process, you come to really a risky patient if you have the APC resistance by a factor 5 genetic mutation, homozygous mutation. Then you have the problem that you have a lot of these hypercoagulation and you can get really thromboembolic complications. On the other side, we know that this fibrin clot you see on the right side, the fibrin clot also is not the end of the whole process, because our body tries always to bring the fibrinolytic response to the infection. So that means also our body tries to get the balance of both processes, which is interrupted by the invasion of pathogens. This fibrin deposition, it grows over time for sure, but so long the infection is active, so long you will produce more fibrin. By this, it blocks the passage of oxygen. So that means patients suffer from oxygen deficiency, and I know therapists are using a lot of oxygen successfully for treatment of these patients. And also the nutrients to the tissues cannot arrive because the capillaries, they are, you see here, they are closing more and more by the fibrin. And also, as I mentioned, it diminishes the capillary sizes. So you will see a lot of patients, if you shake their hands when the patient's coming in, you get a first impression, do you have a cold hand, do you have cold fingers? And you will see that a lot of these infected patients, also with Lyme disease for sure, but other infections too, they suffer from dysregulations of the arterial system, of the capillary system. In the next slide, you see that the inflammation is really not to be underestimated. you have the problem that the infected white blood cells are bigger than the red blood cells, and so they stuck in the capillary system. When they infected, you find more and more white blood cells, leukocytes, or macrophages or monocytes, and they are up to 14 to 16 microns. And this diminished capillary size, it's like a logjam. And in the end, you have a lot of hypoxia because 1 micron of fibrin means oxygen diffusion time of 5.3 minutes instead of 2 seconds. And this is what I tried to explain to you on an easy picture. If you shake the hands of these patients, a lot of these have very cold fingers or cold feet. So this can mean also a problem of this hypercoagulation by the infection. I don't want to say that this is all the reasons of it, but also autoimmune disorders can do that, vasculitis, but on the other side, it can be a sign, a clinical sign for you. Borrelia burgdorferi, in 1996, there was a paper about showing that Borrelia burgdorferi induces platelet aggregations, because Borrelia stimulates the leukocytes, and by this process, it induces the platelet aggregation process. It's a clear correlation was shown in that paper, the concentration of Borrelia afzelia, Borrelia burgdorferi afzelia, and the platelet aggregation. So you see in this diagram that the higher the concentration of Borrelia afzelia in this case, the higher is the platelet aggregation. That means that the higher is the density of your pathogen, the higher is the platelet aggregation on the other side. And that means also clearly indication for hypercoagulation by Borrelia burgdorferi. Even we have a lot of reports about borreliosis, Lyme disease, causing cerebral thrombosis. And this is really very interesting chapter that Borrelia burgdorferi can be a trigger of cerebral thrombosis. So it's absolutely possible that patients can get apoplectic strokes by neuroborreliose or by Lyme disease. In this paper in 2016, they said it's an unusual manifestation of Lyme disease, but who knows? Because I'm sure the neurologists who are in most cases not accepting chronic Lyme disease, that they will not check if a patient is suffering from Lyme disease and all of the consequences for therapies. But if the damage is done in the arterial system by the hypercoagulation, by the pathogen, it's not reversible, but you can stop the process maybe. Babesia, you know, is it's malaria-like infection, and also according to CDC, babesiosis can cause a disseminated intravascular coagulation, which is named DIC, or a consumptive coagulopathy, which is really a life-threatening thing. Surely the immune system plays very important role in all of these patients, but babesiosis is really dangerous for blood transfusions and for blood for really weakened patients in intensive care. So some countries are now checking, what I know, for Babesia infections before getting a blood transfusion in the blood of the donor. These findings in a paper from 2004 indicate that the heparin covers the surfaces of the babesial merozoites. You see on this picture merozoites in the right side, and this inhibits the invasion of the erythrocytes. Different types of viruses also can be the reason for hypercoagulability, hypercoagulation. In a paper, it was written in 1999, so over 20 years ago, there was evidence that, as an example, herpes simplex virus 1 and 2, which is herpes of the lips or genital herpes, adenovirus, parainfluenza virus, poliomyelitis virus, echovirus, measles virus, mumps virus, cytomegalovirus, or also human T-cell lymphoma virus type 1 and HIV. They all can do hypercoagulability in our blood. Why? Because these viruses can downregulate the physiological anticoagulant mechanisms and inhibit the fibrinolysis. And again, then you come to the point, there's no balance of coagulation process and fibrinolysis. And then you have the problem that patients can get, as an example, thrombosis by this process. HHV6, we are working now more and more on HHV6, human herpes virus 6. It belongs to herpes virus group, but we know also that in 2001 came a paper that it's also known to drive hypercoagulation. In this paper, the authors, they came to the conclusion that CFS, or it's better to say in England, ME patients with active HHV6 infection have activation of coagulation and hypercoagulopathies. This state is associated with active HHV6 infection. Now you ask how to find out active infections with HHV6. We can do some antibodies, IgG, IgM. But to find out if it's really active, you need a positive PCR and maybe IgM detection in this patient, although IgM can be also polyclonal stimulated. So it's not so easy to diagnose, but you can be sure in the near future I will have a HHV6 ELISpot to find out if it's active or not. It will come, I think, in 1 or 2 months we can do that, and then we know if HHV6 is active or not in this process. On the other side, Epstein-Barr virus is also a very famous virus. We all know about that. Not just Justin Bieber is infected with Epstein-Barr virus, EBV. But we know that Epstein-Barr virus is also a virus which can do hypercoagulation. The hypercoagulation accomplishes 2 things for the virus. In the first, when the blood is getting thicker again, it is more difficult for the immune system to suppress these viruses, for sure, because you cannot reach it. Maybe you compare it with a biofilm or some polymucosaccharides some pathogens are doing. Viruses thrive in the thicker blood, and in the second point, we have also the thicker blood prevents the maximum delivery of oxygen and nutrients at the cellular level. That was also a paper by David Burke, who did a really pioneer work in this, but it's not so very well recognized in the medical world that viruses are also pathogens which can do hypercoagulation, and by this a lack of oxygen and nutrients, and you all know a lot of therapists are working with oxygen therapies or ozone therapies and nutritional medicine like AONM is doing as an example too. Cytomegaloviruses are also able to influence the coagulation system. In this paper, it was from 2005, there was mounting evidence that CMV may play really a causal role in thrombotic disorders. Cytomegalovirus, maybe you know, it belongs also to herpes virus group. It's very similar to EBV, Epstein-Barr virus. For me, always the question in this chapter, maybe these patients suffered from multiple viruses. All of these papers where you can see maybe the paper before was done with HHV6 and Epstein-Barr virus, but in this paper, the scientific universities are just focused on one virus. But the question is really, what about other virus, multiple viral infections, what we see more and more in the patients worldwide. It's not just one virus, we see a lot of viruses, up to 5, 6 active viruses in one patient. It's similar to Lyme and co-infections. The David Burke, I mentioned already the name. It was really outstanding work in the early 2000s. He said clearly that viruses, HHV6, CMV, EBV, bacteria like Mycoplasma, Chlamydia, and Borrelia, yeast and candida as an example, aspergillus, yeast and mold. Also vaccination, also heavy metals. They all can do the hypercoagulation process in our body. So it's again like peeling the onion model. It need not to be just a pathogen doing this hypercoagulation process. It could be also a problem of yeast and mold or heavy metals, or a problem of different of this peeling the onion. The inflammation means always that we have a lot of amount of fiber in our body. We have again oxygen deficiency. We have nutrient deficiency in our body. So we need from therapy side to support oxygen and nutrients, nutrients. On the other side, I say so long the pathogen is active, you work again in the end of this cascade without solving the problem. So my opinion or my understanding is we also need to treat the viruses successfully. We need to bring them away. We need to kill them. We need to destroy them, or we need to bring them back into silent carrier mechanisms. On the other side, if we cannot manage that, we will still work with our symptomatic therapies like oxygen therapies. The anti-cardiolipine antibodies play also a very important role in detecting hypercoagulation. Cardiolipine is a common phospholipid used by to detect the antiphospholipid syndrome, APS, the abbreviation. It's cardiolipine is an important component of the inner mitochondrial membrane. And the interaction of antibodies with the phospholipids of the cell membranes, they, in the end, they have a change of the metabolism in the membranes, disruption of the cell function, and again, we have the problem of hypercoagulation. So why not to test patients with Lyme disease or chronic fatigue, sorry, again, better to say ME. You see this study was done in Italy and not in England, so they name it CFS in Italy and not ME. But I think it's important to check also neuroborreliosis patients because 50% of them are positive for anti-cardiolipine, IgG, IgM antibodies, and they show really neurological abnormalities. So what could be a testing protocol for pathogen-driven hypercoagulation? This is always the question. Should I, looking now for the needle in the haystack, I don't think so. First of all, we should use a checklist for that. We should find out which pathogen could be active in which patient. The GP or specialist for hypercoagulation could do a fibrinogen or D-dimer test or thrombotic profile with you, but I know this is also a question of money. And also we don't have so many specialists for that. But what you can do is a very easy test. It's the ESR. In US, it's the sedimentation rate, and Dr. Burke, the pioneer, he said the normal range for the sedimentation rate should start above 3 or 4. And the values below that are correlating very highly with SFM, soluble fibrin monomer values. As the SFM goes up in the plasma, these molecules forms the dimers, which is very important also in the hypercoagulation process. And this physically blocks red blood cells from settling out of the plasma. And this, in the end, you have a low sedimentation rate, not a high sedimentation rate, a low sedimentation. This is a cheap and easy test to do. And if you have some abnormalities, maybe then you could do the anti-cardiolipine antibodies, IgG, IgM. We are doing a lot of these, and really we find some patients with it, as you have seen also with neuroborreliosis. This is a checklist. I think for Lyme disease, a lot of you have seen that checklist. You know, the symptoms are not specific, and we all know that, but in the complexity, the more symptoms you have on the list, the higher is the probability maybe that you have Lyme disease, Lyme borreliosis. So I think for a good clinical picture, we should fill out some list or Horowitz questionnaire, whatever you want to do. But I think we should do a documentation maybe it's really Lyme borreliosis, because Lyme borreliosis is a clinical diagnosis, and that makes it easier for doctors also to understand if it could be Lyme disease or not Lyme disease. But to me, it's more helpful. I work daily with a co-infection checklist. You see, this is an example. The patient needs to cross the symptoms on this. There's an individual checklist, and this patient said he had or has stomach ache, gut problems, fever, feverish feeling, lack of concentration, memory disturbance, forgetfulness, flu-like symptoms, rashes, heart problems, cardiac rhythm problems, headache, impaired liver function, also swollen lymph nodes, tonsillitis. So you can see a lot of unspecific symptoms again, but in the constellation in the background, this program calculates you which co-infection is on number one. So how many symptoms do you have for which co-infection in this case? And you can see on the right side the statistic program behind that said Coxsackie and echovirus play the most important role with 8 symptoms, and the herpes virus group with EBV, CMV, herpes simplex, varicella zoster virus. Okay, also we need to add HHV6, HHV7, very important in this complexity of the herpes virus group, more and more evidence for that. Chlamydia pneumonia plays a role, Bartonella, 7 symptoms, Bartonellosis, but also maybe Ehrlichia anaplasma and mycoplasma. But you see, the less symptoms you have for an infection, the less is the probability that you suffer really from this infection. So this is really successful work you can do. It costs nothing, and AONM has it also on the website. So this is a baseline for good work, and then you can decide, oh, do I have a co-infection or another infection, a different infection, because not everything is Lyme disease. You can find this checklist, as I mentioned, on the www.aonm.org is one possibility. Also on Armylab's website, it costs nothing to fill out, no money. So you spare money by that, and maybe you can come a little away from the discussion with your doctor, is it Lyme disease or not Lyme disease? Because, you know, it's easier for doctors worldwide to accept another clinical diagnosis in Lyme disease. It's not to bring you away from that. On the other side, it's reality that not everybody is suffering from Lyme disease, and we have a lot of virus infections we find in the patients. We find also Yersinia, Campylobacter. So you need to differentiate what you're suffering from. So this is really helpful tool, and the doctors accept more other clinical diagnoses than Lyme disease. That was the first part. I hope you got some new and more information about that. It's, I think, really interesting for all of us to check for hypercoagulation in patients with bacterial and viral pathogens. But the other thing, I think it's really, really important, the histamine upregulation. And you will see now that we have also correlation with pathogens, stealth infections. Viral and bacterial infections, especially, they trigger mast cell activation. And you find in this overview by the TMS, the Mastosis Society, the mast cell for the mast cell diseases, you find that the infections play a very important role in this, but also stressing factors of food or beverages, alcohol, drugs, whatever, natural chemical problems, cyanide mechanical irritation. So you can see infections play surely a role in mast cell degranulation, mast cell activation process. Because Borrelia, as an example, since 1999, it's known that Borrelia burgdorferi spirochete induces the mast cell activation and cytokine release. This is no surprise. In this paper, 20 years ago, 21 years ago now, the authors report the partial characterization of Borrelia burgdorferi spirochete activity, which induces the mast cells to undergo a low-level degranulation, which is the baseline for the secretion of the pro-inflammatory cytokine TNF-alpha. You saw it also in the model I showed you in the hypercoagulation with the TNF-alpha, which plays a very important role in the hypercoagulation process too. mast cells activated by the spirochetes, in vivo, it's in vivo model, it's not in vitro model, they participate in the subsequent immune and or inflammatory events. The early TNF-alpha production by spirochete-activated dermal mast cells would help initiate local inflammation. So then the attraction of the inflammatory cells into the sites of the spirochete replication in the skin. So we have that model by Borrelia burgdorferi. And these early inflammatory responses would lead eventually, they said eventually because not so much science was done afterwards, but it was a hypothesis for sure that the generation of the T and B cell dependent acquired immune responses which control the spirochete replication. And in a paper 2017, there was a revival of that. And in this, there was clearly found that the first time the bacteria Borrelia burgdorferi has the ability to induce the inflammatory response in a mouse primary mast cell. They showed, these authors in 2017, that OSPC, which is outer surface protein C from Borrelia burgdorferi, lipoprotein is involved in the early transmission of Borrelia. We know that, but it induces the degranulation of primary mast cells. So you say now it's a mouse model again. Yeah, now we need the human models for sure to prove that in humans. Bartonella also attracts mast cells and triggers histamine release. In this paper, it's also from 2018, it's not such an old paper, they checked for Bartonella henselae, which is the main pathogen for cat scratch diseases. If you have a cat, it can be also transmitted not just by ticks, by cat scratches. But the Bartonella henselae, it overactivates the MCP1 gene, and the functions of this gene to explain. To luring monocytes and T lymphocytes, eosinophiles, mast cells, and basophiles, and it stimulates also cytotoxic destruction of the cells by CD8 plus lymphocytes and natural killer lymphocytes. And additionally, it affects the release of histamine and the synthesis of leukotrienes by mast cells and basophiles. So you see that in this paper also we know that bartonellosis is or can be a reason for histamine release by the mast cells. Mycoplasma, it's also on the complexity of chronic multiple infections with bacteria. We have a paperwork also about that Mycoplasma pneumoniae induces the mast cell activation and the degranulation. It was a paper from 2015. Chlamydia pneumoniae, which is one of my favorite pathogens. It's very common in the world. But it plays also an evident role of histamine release in Chlamydia pneumoniae infections. And this also a very old paper from 2003. Maybe you need to know that we had a hype in 2003, like now with Lyme disease. We had a hype in 2003. Professor Stratton is one of the names behind that. And we had the hype with chlamydia infections in the world. And that was also not so accepted in the medical communities by majority of doctors. And interestingly, it was completely shut down, the chapter with chlamydia pneumonia infections. And you all heard about maybe by Eva Sapi's New Science that she found really Borrelia burgdorferi in communities in skin biopsies with chlamydia pneumoniae and biofilms. This also really some interesting change now. So multiple infections seem to be very common with Borrelia burgdorferi, Lyme disease, and chlamydia pneumonia infections. Yersinia enterocolitica belongs to the enterobacteria, and it's very common if you maybe you know Salmonella. Salmonella is more famous than Yersinia infections. Yersinia infections are gut infections. You can acquire by chicken or by eggs or by mayonnaise or ice cream, so it's all over the world. And it makes similar symptoms to Lyme disease in comparison with Lyme disease. So you have, as an example, arthritis, cognitive dysfunction, chronic fatigue. It makes also neurological problems, or ME, it's better to say again, sorry for my expression. And Yersinia colitica is an enterobacteria, so it mimics a lot of Lyme disease symptoms. And we can test as an example for Yersinia by IgA, which is a very good test for reactive arthritis. And also the ELISpot is really a good test for both to find out if Yersinia may be the reason for your symptoms and not Lyme disease, or both together. The histamine release is also proven in a paper from 2006 for Yersinia enterocolitica. And coming back, this is gut bacteria, and you know, a lot of patients, they, when also I talk with them, they have gut issues, they have intolerances, they have histamine problems, they cannot tolerate wine or red wine or fish together or garlic. So you all know that that maybe there's a correlation also with that. And but again, you could fill out the co-infection checklist, and then you know if you have symptoms for Yersinia and or Campylobacter. Campylobacter is the next chapter. I don't have a slide about that, but they are very close. These bacteria is very close to Yersinia infections. So the mast cells recognize and respond also to viruses. Coming back to the viruses, so we have now, or I've now explained a little about the bacterial world. Now I want also to show you some virus infections. In this model, you can see from 2015 that influenza A virus. Now we have the coronavirus. Don't want to talk today about that, but coronavirus is also similar to that in the mast cell recognition and declination of the mast cells. So the patients, as an example, with this coronavirus, they also get different other problems with histamine release. It's not just the pulmonal symptoms, so it's a cascade of different symptoms in these patients, like influenza is doing similar, or the chicken pox virus and all of this. So you see that these viruses really also release cytokines. TNF-alpha again, interleukin-6 plays a very important role, interleukin-4, interleukin-5, interleukin-13, 17, and VEGF. VEGF plays, interestingly, also a role in Bartonella infections as an activity marker. So you see that it's very close together, and these cytokines are not specific for infections. Also, VEGF is not high specific for Bartonella infections, as it postulated, because all the viruses are doing that. But the specialists for Bartonella are not checking for viruses, so there's a lack of checking for viruses also for them. The mast cell activation can participate in limiting viral replication in the local tissue and the viral dissemination. So it makes sense that in the tissue, the mast cells, they are activated by the viruses, and you have a cascade of actions to overcome this pathogenic insult. So it makes sense in the natural defense mechanism. On the other side, you have a lot of histamine release, and you all know the side effects of that. But if you, as an example, if you sneeze, you have an influenza or a rhinovirus, which is a very mild form of a virus, then you know that what is happening with you to sneeze, and by this process also you infect the other surroundings. So all masks in the world are now sold out. I got the last 10 today. Coxsackie, an RNA virus, which is one of my favorite viruses to say. It's an enterovirus. It's similar to poliomyelitis virus and to echovirus. They belong to the same enterovirus group. It's an RNA virus. And what you can see here, that Coxsackie infections were found to upregulate T toll-like receptor 4 on mast cells and macrophages immediately after following up an infection. And it's an enterovirus. So if you have a gut issue, it's clearly that you should normally check for enterovirus or enterobacteria like Yersinia, Campylobacter, Coxsackie virus, and echovirus. I think it really makes sense to do panel testing for that if you suffer from food intolerances, histamine problems, and multi-chemical sensitivities. Also, Cytomegalovirus, we come later to that, plays important role in the complexity of multi-chemical insensitivities of the patients. We have found a lot of these now. So Coxsackie, you see in this paper, is dangerous. It can do also myocarditis, and you can die by that. And to say, a lot of patients who believe they have Lyme disease are not suffering from Lyme disease. They suffer from Coxsackie virus and maybe echovirus. Both viruses, I don't know why, are very, very close with the symptoms to Borrelia. Maybe Borrelia is triggered or had triggered these viruses, or maybe you do a lot of treatment for Lyme disease, but please don't forget the enteroviruses and enterobacteria if you have still a gut issue. And the longer you take antibiotics, the more gut issues you will get, and the more Coxsackie, Echo, and Yersinia and Campylobacter problems you will get. So be careful in taking antibiotics, and to oversee the viruses and the other enterobacteria, just to give you that message, which will be the next chapter in the complexity of understanding chronic multiple infections. Oh, sorry, go back. I forgot to say, this is very important. Coxsackie virus, interestingly, I did a presentation for AONM 2 years ago about autoimmune disorders, and there was interesting information that also Coxsackie virus makes diabetes mellitus and Hashimoto's. So Coxsackie virus is also a virus, not just Lyme disease, which can induce autoimmune disorders like Hashimoto's, and diabetes mellitus, and also juvenile diabetes mellitus. So if you suffer from diabetes mellitus or glucose tolerance problems, please check yourself again for these enteroviruses. And some of you, we see blisters in the mouth, which are coming and going, and this can be a sign for reactivation of this Coxsackie virus, which is named herb angina. So this is very common in the patients I see nowadays. Some of them, they maybe had Lyme disease or other co-infections, but when they come and I see the blisters, this is not Lyme disease. This is also not herpes simplex. This is Coxsackie virus infection and echovirus infection. Coming back to the enteroviruses, enterovirus 71 infection is also described as mast cell activator, and it can also do allergic inflammation intolerances in target organs or tissues. So I think in the future, we will be focused more and more on the gut, on the enteroviruses and enterobacteria. This will be one of the challenges for the future. So what could be a testing panel for histamine upregulation, MCAS? Just some considerations. Borrelia burgdorferi, you have seen, we know we offer the ELISpot, you know, and the tickplex basic. It's not the whole tickplex. The tickplex, I think it's really helpful now. We can find out persister forms, which is really helpful, IgM, to find that in patients. But also chlamydia pneumonia, you have learned, can be the reason or associated with histamine upregulation, MCAS. Mycoplasma, we have seen Bartonella, we have seen Yersinia, Campylobacter, question mark, any viruses, enterovirus, Coxsackie virus, CMV, it's also gut virus, EBV can be gut virus. So again, I would always do the co-infection checklist to find out if you really suffer from that or not. And this is, I think, one of the keys to find out. But if you have a gut problem, in every case, I would check you or the patients for this enterobacteria, Yersinia, Campylobacter, and the enteroviruses for sure. So this is now also, I'm coming to the end. But we have another interesting conference. Maybe when you are in London, you are heartily invited to come to the next with a conference from AONM organized. It's with Dr. Joseph Jemzek, and some of you have heard that he got his license back, which is good for the Lyme community to treat Lyme disease. And I myself will also be there, but we will also get some other international experts there. The date is 3rd of May. Yeah, and then now I come to my end, or the end of this presentation, not my end. Thank you very much for your attention.
Thank you very much indeed, Armin. That was stunning information, really, really fascinating. We do have quite a few questions. So because we just have another quarter of an hour or so, I'll start asking them right away. And do, of course, put in any further ones that you'd like to ask as we go along. The first one here is, what is the best test for active Epstein-Barr virus, please?
Yeah, clear answer. This is a test from transplantation medicine. It's the EBV ELISpot, and the lytic antigen is the most important in this. So it came from transplantation medicine. You have it in a lot of countries, the ELISpot, for this purpose, but not for chronic other illnesses. It's the EBV lytic antigen. If this is positive, and we see many of them, then you suffer from active virus replication. It's the same like you would do in transplantation medicine, the test.
Could you explain just briefly what the difference is between lytic and latent in the ELISpot? Because we get quite a lot of information when we do the ELISpot, and the other marker is the latent.
Yeah, when I heard first time these expressions, I Googled myself, and Wikipedia is a good thing for that. Latent means, let me say it, a latency is sleeping form. So a lot of you or us had this virus. It's a kissing disease, infectious mononucleosis, it's named, when you're student disease or whatever. But you could have it latent, and then the latent ELISpot might be positive. But if you find a lytic positive, lytic means an active replication process, then it's not sleeping, then the virus is active in your body.
Thank you. Another attendee asks, do you know if lupus anticoagulant is a growing phenomenon in hypercoagulation? Does that play a role as well?
Yes, I worked for Synlab Group a long time, and we did a lot of lupus anticoagulant. The test is not easy in laboratory medicine. We left it more and more to the anti-cardiolipine IgG, IgM when it came up, the ELISA, which is more, let me say, sensitive and also specific test now. So the lupus anticoagulant, you can do it if laboratory. It's a coagulation test, so you measure the seconds by that process, but it's a older method. It's an ancient method. I would not do that. In the modern laboratories, we do the anti-cardiolipine IgG, IgM ELISA.
Thank you. Okay. Another participant asks, what's your opinion on the measurement of CD57 and how it relates to the health of the patient?
Yeah, CD57, when I came to that, I never heard about that. It was 1997 or so. I heard the first time, and the doctor said to me, who worked in that field, yes, it's a neuroborreliose, or 2001 it was, not 1997, 2001, 2002. And Ray Stricker is the father of that. Ray Stricker was ILETS president, and Ray Stricker is in San Francisco professor. He compared his HIV patients with neuroborreliosis patients in San Francisco in his clinic, and he found a significant decrease in neuroborreliosis versus his HIV patient. He ran a lot of these CD markers, and by that he brought up it's a marker for chronic Lyme disease, or maybe it's a chronic marker for neuroborreliosis. But When I met Ray Stricker some years after in Aarhus University, 2006, I asked him, Ray, when we did some breakfast together, Ray, did you check for chlamydia or mycoplasma, if it can also do low CD57 cells? And he said, no, I mean, maybe you can do that. And now I think it's more and more evident that it's not a specific marker for Lyme disease, as he thought, because he didn't check for all of these other bacterial infections. But to me, it's a marker now for an active chronic bacterial infection if it's low. But you cannot say if it's low, it's really a bacterial infection. You need the complete picture, and you need to know is really any bacteria active or not. So which bacteria is active? Maybe Yersinia can also do that. And again, we need studies, but you know, in the guidelines of neurologists, everything is blocked by that. But this is, I cannot tell you. So we need really some evidence-based work on the different pathogens, which can do low CD57 cells or not.
Okay, thank you very much. Just to clarify, because one attendee has asked what EBV means, that's the Epstein-Barr virus. Another term for that is glandular fever. Mm-hmm. One aspect of that is mononucleosis.
Exactly. Kissing disease, yeah.
If you suffer from Lyme and co, should you treat the Lyme first or the co-infections first, Armin?
Islets now changed the word to other infections, and I think it's correct because the word co means it's a little domestic. Borrelia is the main infection. But who does the definition? What is the main infection? They are together, you know. What is a dominant infection? I think it's better to say other infections. Lyme is for Borrelia burgdorferi is one of these multiple infections we find. So, but for me, again, I want to know what is the dominant infection every time. Is it Yersinia? Is it Campylobacter? Is it herpes? What is it? Or is it maybe Borrelia? And Borrelia can be the dominator, but it can be also a co-infection. Maybe we bring it around the other way.
Okay, thank you. Well, that's a big topic, isn't it? And that's maybe something really that we'll be focusing on more in a future presentation of yours. Yeah. Another attendee writes here, at the start you said that hypercoagulation can be good or bad. Could you give us a simpler explanation of what the good is and what the bad is, just to kind of summarize it?
Yeah, the good thing is if you have a pathogen, it's a protection mechanism, like biofilm. On the other side, you need to bring away this thrombin again. But if you cannot find a balance, it's the same with circulating tumor cells. The same principle. We need a balance, Th1, Th2 system. We need the balance with this thrombin, antithrombin. If there's a disbalance in this, then we get problems. You saw it in this first slide, but one of the first slides. But if the balance is not given, so it can be a good thing, it's a good protection, but it can be a bad thing if the problem is not solved. And the problem is, in this case, where I talked about the infection.
Absolutely, thank you. This is a big question, of course, and we might need a separate session on this, but another person asks, what are the different ways to treat hypercoagulation?
Yeah, to treat it, you can treat with anti-coagulopathy therapy. It's like heparin therapy, as an example, because otherwise you have the risk for apoplectic strokes or embolism in the body. You get a lot of other problems, you know. So the perfusion is not good. You need to bring fluid. You need to remove the reason for that. If you cannot remove the pathogen, you will still suffer from it for sure. On the other side, you remove the pathogen, and then also you need to work on the oxygen, the nutrients, as I showed. You need to work on the perfusion. You need to drink a lot. But you know, a lot of patients, as I mentioned, have a lot of problems with the perfusion, and they don't drink, they don't eat, they eat wrong things, fatty things, whatever, sugar. So we need really to be focused on the natural ways and not to use heparin in injections. You know, you can do that for sure if you have some problems with that, but this is also not the solution.
Right, thank you. Yes, there are quite a few questions focusing on that, so we may need a separate session on this. Will treating the pathogens indirectly treat the hypercoagulation, or should a specific intervention be introduced?
Yeah, this is a good question. As I mentioned, also not all is the pathogen. You also need to check for other reasons for the coagulation problem. Maybe you have autoimmune disorders. The ANCA play a very important role. The vasculitis marker, as an example, we find patients with this, or anti-nuclear antibodies. These autoimmune disorders play a very important role in this. This is a challenge. We cannot say where to start, and we don't have also again the money, and we don't have the possibility to check for all, but you can be sure so long the infection is active, you can do what you want. In the end, you will not solve the problem.
Thank you. There are quite a few questions here relating to other topics, which I think we need to gather and make sure we address in future sessions, such as patients talking about their diagnosis and treatment and when they should retest to find out whether the Borrelia has been eradicated. I think we'll sort of bracket those out until another time. One very specific to hypercoagulation is an attendee saying that she's lupus coagulant positive but cardiolipin negative. So if you only test cardiolipin, you might miss that group. Is that something you've noticed before? You talked about your work previously at SynLab and so on.
Yes and no. Also, the lupus anticoagulant can be unspecific or too sensitive. So this is a screening method, you know, and it's in laboratories. We don't like it really. So I would more tend in this that it's unspecific reaction, but you need to check why is it. Maybe by hem agglutinins or some other reasons for that. This is not to let you alone in this situation. So you need to do differentials why you and maybe you repeat this test, because this test is not so very well standardized in laboratories.
Okay, that's interesting. Thank you. Well, we're coming to the end of the time here, and there are many, many more questions. So I think we need to gather them and just make sure that we focus on them in a specific.
Oh, we can do some. We can do some.
We could have a sort of question and answer in the future.
Let us do.
We're not so much doing a sort of top-down presentation like this, but leave more time for questions. The last question that I'd like to just mention here is, if coagulation is treated successfully, in other words, eradicated in a satisfactory manner, is that a way to get rid of mast cell activation syndrome too, would you say?
Yes, if you bring away the pathogen, then sure, you have one problem excluded. But the question is if, like in autoimmune disorders, the patient could get own standing problems afterwards. You know, it's not guaranteed that if you really bring away the pathogen, that your histamine problem is resolved by that. That's maybe it's also different peeling the onion way, as I mentioned. It's also stress to get whatever, and it's not. It's a multi-systemic problem. It's not just infection.
Thank you. Thank you. Well, other people have asked here, will this recording be made available? Most definitely. If you look at our website under events, there's a pull down menu. And if you look at the top of that, it does say past webinars. And there you'll be able to access the recording free of charge. So that'll be made available as soon as we can. Thank you so much again, Armin. Just to mention once more the different events this year, because we have a lot. Armin will be speaking on the 3rd of May at the Big Lyme Conference we have here in London. And then we have our annual conference where Lyme will definitely feature large as planned, but we also will be covering other topics on the 15th of November. We do have a cancer conference where we're still hoping that Armin will be able to attend on the 6th of September, even though that does clash with the ILADS meeting in the States, so he's doing what he can. We may also wiggle the date a little bit to be able to include you, Armin. And then he is also speaking in just 10 days or so in London at the conference called A Future Without ME of Dr. Klinghart's, which you can read more about on the webpage, klinghartinstitute.com. We're so glad that you're able to make that as well, Armin. So otherwise, we'd like to just mention that we'll be having more webinars of this kind, and the next topic that Armin will be talking about personally is the effect of infections on the gut. There is actually in our latest newsletter, which came out yesterday, an article about GI borreliosis, and he'll be very specifically talking about that. So we haven't got an exact date yet, but we will soon, and look forward to that. Thank you so much, Armin, again.
Thank you to all, and have a good night. Thank you.
Thank you. Bye.
Bye-bye.